Good evening, everyone. My name is Denise Mananis. I'm the Director of Marketing, Public Relations, and Development for St. John's Riverside Hospital, and I welcome you all to our Stroke Time is Brain program this evening. With me today, I have 4 guests. To my right, I have Dr. Imad Solomon. He is our Medical Director for the Stroke Center. To his right, we have Darren Baya, who is the Director of Clinical Services for Empress Ambulance. We have Linda Segru, who is our Stroke Coordinator, and we have Dr. Rafael Malizia, who is the Medical Director of the Emergency Department here in the Andrews Pavilion of St. John's. This is Stroke Awareness Month, and so St. John's is celebrating with a whole lot of community programs and educational programs. And so we wanted to talk a little bit about the process, prompted really because we can congratulate ourselves, I think. We can make an announcement that St. John's has been awarded a Silver Plus Stroke certification for our stroke center here, and that's a really big deal because there's an awful lot that goes into it. So without further ado, thank you all for joining me tonight. And so, Doctor, I'm going to start with you first. I want to ask you, and I'm going to give you the microphone. Can you explain to our audience what is a stroke?
So, thank you for inviting me and to this talk. Stroke basically is a neurological condition. It's an insult to the brain. It's a brain attack, and it's basically has 2 kinds. Either there's no enough blood going to the brain, or there's too much blood going into the brain.
Okay. So, what are the risk factors for a stroke? Anybody can answer, but let's start with you.
I mean, the number 1 still risk factor for having, I apologize for this.
It's okay, it's the life of the dog.
The number 1 risk factor for stroke still is the hypertension.
Other risk factors?
So, I mean, smoking is a risk factor, high cholesterol is a risk factor. African American population have twice the risk of having stroke compared to Caucasian people. Age is a risk factor. We usually divide them into modifiable and non-modifiable. The modifiable factors like the hypertension and the smoking and the being overweight, we can change. The unmodifiable, as the word sound, would be the African American aging as a crisis.
Is gender a risk factor?
Yes. It is. I mean, I would say that the latest statistics from the American Heart says that the women have twice the risk of having stroke as a man.
So women have, hello, welcome. So please take a seat. So women have twice the risk of men. Why is that? Is that a genetic thing? Is that something different?
We really do not know specifically. There's no biomarker or biogenetics behind it, but we think that women live longer and maybe they have a higher risk of having the predisposing factor from atherosclerotic disease to hypertension to cause a stroke.
Okay. So this has 2 parts, this question, because if you do not have a predisposition, if you don't have one of those risk factors, can you still have a stroke, and how do you prevent the stroke?
Yes, and it happens in our institution at St. John's or at Dobbs Ferry Hospital, that we see patients that they come presenting with a symptom of these, either what we're going to go into a transient stroke that came and went away, or a real stroke with a deficit. And we do what we say, the $1 million workup, and we can't find the source of the stroke. So we can have what we call stroke de novo, which is stroke with no real factor. The cholesterol is good, the blood pressure is good, the patient's not smoking. their body mass index is good, so we still, we don't know where the stroke came from.
Also, just something to keep in mind is that all of those risk factors really predispose someone to having the clotting form of the stroke, which is the one where not enough blood is getting to the brain. But people can have the bleeding form of the stroke, it's called a hemorrhagic stroke, and really you can have that, it's typically from aneurysms that can be asymptomatic or unnoticed, and that can happen really in any age group and to someone with no medical problem. So that's just the other thing to keep in mind. The presentations are sometimes, often different, where a bleeding stroke will have a severe headache, but that's just the other side of that Dr. Simon mentioned in terms of types of strokes.
So in terms of prevention, if you have risk factors and you know you have risk factors, what can you as medical professionals advise people to prevent a stroke?
Again, number one is still the number one according to the guidelines is the blood pressure. So blood pressure, blood pressure, blood pressure. And as we call the other name for the blood pressure, the silent killer, whether for a stroke or a heart attack, so controlling your blood pressure is the number one factor. Having periodic visits with your family doctor or the primary care physician to control your blood pressure and make sure that your blood pressure is under control, whether by guidance and lowering the salt in your food and exercising to taking medication, of course.
Okay, so aspirin seems to figures into this equation a great deal as something that people can do to prevent a stroke. Aside from aspirin, and who should take aspirin, but what are the other kinds of treatments out there to prevent having a stroke?
So aspirin, a lot of patients ask us about as medical professional, do I need to take an aspirin? And the answer is aspirin is not for everyone. And I would like the general public also to kind of remove the idea that we are taking aspirin at home as a remedy for pain. It's a painkiller. It could help with pain, it could help with arthritis. But we as neurologists, and specifically for our talk, to lower the risk of having a stroke, we advise for the aspirin, but it's not for everyone. So as Dr. Malizia indicated, patients who come in with what we say hemorrhagic stroke, that there's too much bleeding in their brain, they cannot have aspirin. So the answer to the question whether do I need an aspirin or not, you need to consult with your primary care doctor, with your neurologist, with your cardiologist, or definitely we will answer this question for you if you come to the emergency room.
Doctor, you have anything to add to that?
No,
Okay. So there are other kinds of heart disease and stroke prevention drugs, statins, anticoagulants, AFib drugs. Can you talk a little bit about those and the role in prevention?
So, in terms of atrial fibrillation, so atrial fibrillation is another risk factor for those clotting kinds of strokes. And atrial fibrillation is an abnormal heart rhythm that doesn't move blood through the heart the way we normally would. And so that blood tends to get a little stagnant and can clot. And those little clots can sometimes sort of shoot off and cause a clotting stroke. So for that reason, atrial fibrillation is treated long-term with blood thinners. And now there's many different types of blood thinners on the market. So if your physician thinks that you're a candidate for these types of blood thinners and recommends it to you if you have, atrial fibrillation or some other heart condition like a valve, like a mechanical valve in your heart, then taking those blood thinners can help prevent the complications like stroke.
Okay, so those are,
Absolutely, it's all yours.
We get asked a lot of times the question regarding, do I need a baby aspirin? Do I need 2 baby aspirin? Do I need a full aspirin? And the answer to this is, we have studies in neurology and cardiology in terms of what we call primary stroke prevention, to prevent stroke from happening from the beginning. To secondary stroke prevention, that the patient had a TIA or a stroke. And the answer is this, to this, there's no 100% answer, but again, it should be according to your neurologist, cardiologist, working in collaboration with your primary care doctor, your family physician. But everyone is different, and I advise always my patient that this is a blood thinner, this is a medicine, this is not something that we should take as needed. We should follow the guidelines. Every medicine is a chemical and comes with a side effects. So to answer the question about do I need a baby aspirin or 2 baby aspirin or a full aspirin, I will listen to my doctor and get visit.
So you bring up an interesting point in this day and age where people also are kind of a little bit suspect of so many medicines and being on so many medicines. Are there natural remedies, natural preventive, holistic sorts of things that can be taken by patients that are safe, that actually have some good effect?
I know like fish oil is commonly used in terms of cholesterol management, but I don't know if there's actually any studies showing any benefit. But I know that someone sort of out there in the public's knowledge, and that some primary physicians or family medicine doctors will recommend. In terms of data or in the medical literature, I'm not sure if anything's been completely tied to stroke prevention.
We get asked a lot about medications and remedies over the counter, and me and Dr. Melissa, we practice evidence-based medicine, and I say to my patient, if you show us a study that shows that this kind of remedy or this kind of over-the-counter homeopathic treatment will help prevent a stroke, we'll look into it. And we have to be very careful when we analyze where the study is coming from, who published the study, which medical school it's linked to. But the point also that as we know for a fact that the stroke happens in elderly people, and I always advise my patients and patients in the hospital or the emergency room or in the office that we are taking multiple medication. And whatever you take over the counter, you have to make sure that it doesn't interfere with your other medication. It doesn't raise your blood pressure, it doesn't interfere with your cholesterol medication. So whatever you're picking up from over the counter or a friend or you saw on the TV on a commercial, we have to make sure, run it by your doctor again, make sure it's compatible, make sure it doesn't have any side effects or contraindication.
Okay, so earlier I announced that St. John's is the recipient of the Silver Plus Stroke certification, and that is through the American Heart Association and the Department of Health. And that is a really big team approach, which is why we have 4 members, the 4 primary members of that team who helped St. John's earn that certification. So I actually want to turn it over a question to Darren, who's from Empress Emergency Services. The partnership between the ambulance and the people on the ground outside the hospital and the emergency department, can you talk a little bit about that relationship and the partnership that has been established here?
Sure. Well, we meet on a regular basis, reviewing calls, strokes, going over timelines, different protocols. We've set up some protocols just for St. John's, how to treat them much faster in the emergency room, getting patients here faster.
So can you tell me when an ambulance gets a call and it's a potential stroke patient, what happens? What are the people in the ambulance? What's their protocol? Can you start from that point and sort of take us through to when they arrive at our doors?
Okay, well, the first thing is if anyone is feeling signs or symptoms of a stroke, to call 911. This time is of the essence. The paramedics arrive, they do an exam on the patient, they check vital signs, they check for any kind of deficits, neurological, the fasting that the American Heart, emphasize out there about pace, looking for slurred speech, arms drifting, maybe they're holding up in the air, and then just calling 911. So once the paramedics determine that they have a possible stroke, they're going to transport to the closest stroke facility, which is St. John's is one of them. We give them an alert on the phone prior to arriving. Everybody is ready when we arrive at the emergency room. We've set up a protocol when we come to the emergency room that the patient doesn't even get off the ambulance stretcher. They're taking the patient right to CAT scan to get some immediate testing so we can save as much time as possible.
Okay.
Let's step back a second. So you said that you take the patient to a stroke center. So why is that important, and what's the difference between that protocol and what is that protocol, and how does it differ from just another community hospital that doesn't have that protocol in place?
New York State sets the guidelines for a stroke center, and St. John's has got the protocol and personnel readily available to treat the patient and evaluate the patient. So they have their, I'm not sure of all the steps, which may be documented, and they have a process.
Okay, so let's turn it over to these two. So Linda and Dr. Malizia, either one of you want to start?
So we'll start with the idea of being a stroke center. So in order for a hospital to be a designated stroke center, they need to be working with the New York State Department of Health, so that the expectation when you're designated is that you are able to provide for the community a certain level of service and certain best practices. And part of those best practices are time targets, meeting criteria for administering medication within the proper time frame, having CAT scan capability 24 hours a day, 7 days a week, MRI capability, which, as you know, is critical in the initial stages of stroke diagnosis. Stroke education is a big part of that. Again, we mentioned the time targets, because woven throughout the continuum of stroke care is this theory of, this theme of time is brain, and every minute counts. And so when our EMS crews get a call for a potential stroke, it starts the clock ticking. And when they pre-notify us, they will call and they speak with Dr. Malizia, and they'll inform Dr. Malizia we're coming in with a 75-year-old, 80-year-old patient presenting with slurred speech, sudden onset of weakness on one side. And we, in turn at the hospital, are ready, as Darren touched upon, and once they roll in the doors, we have more time targets that we really want to strive for. So at the end of the day, we have pieces, all these pieces together make up what a stroke center is. And it's basically to give a good continuity of care for stroke care, and it's commitment to stroke care from start to finish. So do you want to take over from when they come in?
Sure, yeah. So, part of the processes that we've implemented to meet the goals of New York State and what is happening nationwide integrates the entire system. So the sooner the patient activates 911, the sooner 911 gets there and can assess the patient, the sooner they can give us notification, and then we can then prepare to do our part. And in the ED, I sort of equilibrated this that we have to try to streamline a stroke patient's visit, and what would normally happen in about 2 hours needs to happen probably in the first 30 to 40 minutes. And so being notified by EMS is really the best way to do that, because we can prepare our stroke team. We can pre-alert the hospital, and that involves both the lab and the CAT scan, the imaging, so that we can perform that initial CAT scan. And through something we call a code gray, which is sort of announced overhead at the hospital so that everybody's aware that there's a patient in the ED who's going to have these needs. And so when we get alerted by EMS, we have a dedicated physician and nursing team and assistant team that basically prepares a stretcher and waits for the patient's arrival. Registration is also there, and so upon arrival, the patient is immediately evaluated by a physician in a screening exam that typically takes less than 1 minute. During that time, we're also making sure that the patient has some blood tests that are drawn if EMS hasn't done it already, and they often do. And then with that notification, we can then bring that patient directly to CAT scan, because CAT scan presents sort of the first branch in the algorithm in terms of where we're going to go next with that patient. So in terms of involving the entire system, the best way to do this, if you have the symptoms of a stroke, or if you feel, or if you're with someone who may be having the symptoms of a stroke, is really to call 911, because that helps us start taking care of you before you even get to that situation.
So there's a lot of, and this treatment has been around for a long time, but can you talk about TPA, when it's indicated, when it isn't, what is it, and why it's great?
So yeah, I'll talk a little bit about TPA in the emergency department, and I'll let Dr. Solomon talk about some of the numbers and the benefits and the risks. So, the goal in terms of our initial assessment of a patient with a possible stroke is that if this stroke is a clotting stroke, we can potentially give you a medicine. It's called TPA. It's basically a medication that breaks up clots in your blood system. And there's guidelines in terms of when that can be administered. And so the general guideline which we've adopted here, and which is the standard, is that if you can document that a patient was last known well, is the term that we use. So last time they were normal was less than 4.5 hours prior to visitation or prior to arrival, that they are potentially a candidate for this clotbuster. And so in the ED here, we try to streamline that whole visit so that within 60 minutes of arrival, if you're a candidate for this medicine, we can begin the infusion of this clotbuster, which takes about an hour overall. And so that's why things tend to happen very quickly, is because we are on a timeline. That timeline is not only to meet guidelines, it's also for this whole concept of time is brain. The more time you spend allowing that clot to block blood flow, the more permanent damage potentially is happening. So I'll let Dr. Solomon talk a little bit about TPA in general.
So it is a medication that we use, and I just have to make sure that this is not for every patient that comes with a stroke. As Dr. Melitza said, this is only if you have a blood clot. And based on the initial presentation from the EMS, have been great communicating with the emergency room physician what kind of presentation the patient is coming with, whether the patient is unable to talk or weak to one side or the other side. And we, again, not to repeat, that we get the staff and the emergency room prepared for this patient coming to our facility. But we have an idea where it could be a stroke, and we rush the patient to the CAT scan, which is the X-ray of the brain, to identify what kind of stroke the patient is having. And if the patient fulfills certain strict criteria, and in communication between the emergency room physician and the neurologist on site, then we can decide if the patient will be a candidate for this medication. Again, this is a very strong blood thinner. It's not indicated for everyone. It got FDA approved by the Food and Drug Administration to be used for clot-associated strokes back in 1995. It carries the risk because it will thin the blood everywhere. So we communicate with the patient's family that giving this kind of medicine is risky. The patient will benefit from it, but there is a chance that too much blood can convert into a bleed into the brain. So we're very strict, and we follow the guidelines from the American Heart, the Food and Drug Administration, using this medication in the emergency room.
So if you're not a candidate for that kind of administration, or for that kind of medicine, and you have a brain bleed, what do you do for that type of stroke?
Yeah, so for bleeding strokes, the management is very, very different. One is, if you are on any of those blood thinners that we talked about, whether it be aspirin or some of the other blood thinners, part of the next steps we take are reversing the effects of that of that blood thinner to try to minimize the extent of more bleeding. Some of the other important, factors up front are blood pressure control. Sometimes, bleeding strokes can be either caused by or worsened by very high blood pressures, and so blood pressure control is important, and it's fine tuning so that we make sure enough blood is still getting to the brain, but not to the point that it's making the bleed worse. These patients, and then some of the larger bleeds may require some surgical intervention.
Okay, so you, doctor, had touched a little bit on what a transient ischemic stroke is. Can you just explain that a little bit more and talk about, why people don't recognize them as strokes?
So basically from the word TIA, or transient ischemic attack, or the other name for it is a mini stroke, which I personally do not like to use, because if I use the word stroke, that means that there is a permanent brain damage or permanent brain insult. But from transient, the word transient means that there is a lack of blood flow to a certain part of the brain, and this blood vessel, this peculiar blood vessel, reopened again, and the blood flow started again, and the patient's symptoms went away. Still, the definition of the transient ischemic attack is the patient's symptoms will disappear within 24 hours. And the most crucial thing is when we do our testing in the hospital, whether a CAT scan or an MRI, that everything has to come back normal. So if a patient's symptoms went away and the CAT scan or the MRI is abnormal, then it's not a TIA, it is a stroke. Now, TIA by itself is a red flag. We take it very, very, very seriously. In our institution, we admit the patient to the hospital for observation, because we want to make sure that it doesn't happen again, and where is it coming from, and what are we going to do to prevent it from having a real stroke. Patients who have a TIA will carry a risk of having an 8% stroke within the first 3 months. So if we don't do anything, within 3 months, 8 of 100 patients will come back to our institution with a stroke, which we don't want this to happen.
Linda, can you talk a little bit about the signs and symptoms and how to recognize and some of the Heart Association, Stroke Association education that's available in terms of helping the community recognize when someone's having a stroke?
Sure, so Darren touched on it earlier. It's the American Heart Association, American Stroke Association, who actually were in charge of giving us our recognition. So they are stroke champions. They're in the field of stroke, they're just champions. And one of their handy ways to encourage the community to recognize a stroke is by using the FAST acronym, so FAST. So F is going to be for face. So if your loved one or someone you're with has suddenly no movement in one side of their face, you ask them to smile. One side moves, one side does not. So that's your F, so that's one red flag. A, F-A-S-T, A is for arm. So if they are having their arms out and if one arm sort of drifts or doesn't move at all, there's an obvious weakness in that side, that's the A. So now we have F-A. S of the FAST is speech. So if their speech is impaired or if they can't speak at all, that's also a warning sign. And then T, of course, is time to call 911. So FAST, face, arm, speech, time to call 911.
Before we call this program to an end, I wanted to just see if the audience members had any questions that they would like to ask. We have some medical people here, we have some nurses here, we have some community members here. Anybody?
If a loved one, if you suspect that a loved one is having a stroke, is it recommended to give them aspirin before you call the ambulance or while you're waiting for the ambulance?
That's a great question. Who got that? Anybody?
I would not recommend giving an aspirin if you're suspecting a stroke based on slurring of speech or arm weakness or leg weakness. Do not give an aspirin until the patient comes to the emergency room.
Yeah, I would echo that, and you know the benefits of aspirin are not as time sensitive as the clot breaker TPA. So, and if it is one of those bleeding types of strokes, giving an aspirin could potentially put them at higher risk. So the best bet is to just activate the system, let us do our evaluation. It's very possible they'll get aspirin later, but you know we'll have to clear and make sure that that's okay first.
There actually is another warning that you want to avoid giving something if you don't know if your loved one is able to swallow properly. And sometimes stroke patients develop the inability to swallow properly. So you're actually putting them in more harm's way by giving them something orally that they might not be swallowing properly. It could go into their airway, which could cause a whole set of other problems. So the short answer would be no. But that doesn't mean they won't be a candidate for it shortly down the line. It's a great question.
Another question in the back? Anything? No? No? Anything that we didn't touch on that you wanna talk about?
I just want to tell a little bit about how our staff prepares themselves to be providers for you. And our stroke team participates in stroke education training regularly. In addition, here at St. John's, we kind of take it a step further where we provide refresher courses for the stroke team so that they can stay current with the latest recommendations, any changes, any updates. So the exchange of information is fluid, it's ongoing. As in the field of stroke, there are new advances happening all the time, new studies being done, and we want to stay current with that as well. So education is a big part of that. And so is community education. So as Denise mentioned earlier at the start of the program, St. John's is committed to stroke care in the education department. We have events here in the lobby. We have other venues that we visit, such as community centers, health fairs, senior centers. So anywhere where we can get the message out to the community is worth it. It is time well spent. It's good information, and it helps the community take charge of their health care.
We have another question?
Forgive me, I'm curious. We're talking about a stroke. Well, if I suddenly feel like I have a heart attack, or maybe I'm having a stroke, how do I know which is which, or is that too naive a question?
No, that's a good question. It's a good question.
Who'd like that?
So, you know, as Dr. Solomon referred to it earlier, this is, you know, a stroke is basically a brain attack. So a heart attack is when the blood vessels in your heart get clogged and there's no blood flow going to that part of the heart, and you get pain. In the brain, it's a very similar process where a clot gets into an artery, but the brain responds differently. Instead of hurting, you just lose the functionality of that part of the brain. So a heart attack is more chest kind of symptoms, chest pain, or pressure, trouble breathing, nausea, sweating, that kind of stuff. A stroke is some of the things we talked about here, where you lose the function of that part of the brain. So, you know, different parts do different things. Some of the more common things to look for, as we mentioned, your ability to speak, your ability to move your face, your ability to move your arms and legs. And, you know, again, the process in terms of how we intervene is different. And, you know, EMS and the paramedics know those things. And so if it looks like a heart attack, that's gonna start one process. And if it looks like a stroke, that's gonna start a different process.
When people present and it's possible that they're having a stroke, are there other things that could be happening that are not stroke? but that sort of mimics stroke?
Well, the ultimate place to find that is the emergency room, so that's, I mean, no matter what, don't delay calling 911. And time is of the essence of most of the emergencies, heart or stroke. And we're not gonna be able to determine fully in the field until the emergency room does all their tests. So the time is of the essence, right?
Agree with Danny. And the crew, which will, again, be complementing the EMT and press staff, that when they call in, they help us a lot by telling us what the patient presenting with. But again, most of our work from the emergency room physician to the neurologist is to identify what we call stroke mimicals. So the patient could have a seizure, or could have had a seizure, and after the seizure is not moving on one side, the patient had a low sugar and can present with symptoms of stroke. The patient could be confused because he has a fever or UTI, and these are all symptoms that can mimic a stroke, but it's not a stroke.
Sometimes our paramedics in the field will check the blood sugar immediately in the bus or even in the living room. And if the person is a diabetic and had low blood sugar say 30 or 40, that patient will look like they are having a stroke. So their behavior will be different, and medications are given in the bus as well, the ambulance as well. So that could be remedied before the patient has even arrived to the hospital, so that the assessment could go further from there. But yeah, excellent. That's an excellent.
What happens, let's talk about the patient that comes in, it's determined they have a stroke, they were given TPA. What does that patient look like with the TPA?
So, the effects of TPA will only be seen over time, and sometimes we've seen pretty rapid improvements. Sometimes it can take hours or days or weeks, and so we administer the medication. The end result of where those patients' symptoms are going to be, whether they receive TPA or not, are not necessarily guided by their presentation in the ED. Stroke, in terms of its endpoint, is a very fluctuating process.
I have a question for the paramedic training in terms of what the hospital staff do and the physicians do and the emergency personnel do. In terms of training the paramedics, there's special protocols for knowing how to differentiate between somebody having a stroke and somebody maybe mimicking a stroke. How do you get those folks up to speed? What's the process for that?
The paramedics go through a couple of years of training. They work constantly with doctors, reviewing calls, and different situations. But the paramedics will do a full assessment on the patient, looking to see what signs and symptoms they have to determine which kind of emergency they may be having and take them to the hospital. They carry medications. If we have something we want guidance on, we call the emergency room doctor and we discuss the call with them right from the house. And medications may be given and stabilization of the patient.
Linda, can you talk a little bit about the difference between, our certification as a primary stroke center, and I know that there's another sort of a very comprehensive. You want to just talk about that?
So here at St. John's, we have a certain capability in the stroke care continuum. And there are cases when a patient having an ischemic stroke requires further intervention. So they need to have a thrombectomy, for example, where the thrombus is actually seen in the brain vasculature. So a comprehensive stroke center would be the location where that can be taken care of surgically. And so at that point, Dr. Malizia would work on transferring to the comprehensive stroke center. But I just want to touch very quickly what you were talking about your EMS preparing for taking care of patients. Dr. Malizia reviews cases with the paramedics regularly, call audits, and we do provide education for EMS as well to keep them abreast of the new recommendations, anything that comes up. But again, it is a team effort, and it's not a step one, step two, step three. So this it all sort of happens at once. And somebody in the stroke field compares it to the pit crew of a race, so that when the car pulls over, somebody's in charge of the tires, somebody's in charge of the fuel, and it's the same thing with the stroke team. We want fast, accurate care, but we all have a role to play. And unfortunately, stroke is the leading cause of disability in the United States, and we'd love everybody to prevent a stroke. We don't like it, we don't like it to happen, but unfortunately it does. And so one of our goals is to get the patient back to as much activities of daily living that they can. And we have rehabilitation here as well, which is important. That we have teams, we have a physical therapy team, we have a speech and language pathology group to assist the patient with swallowing, because these are life-changing disabilities that we want to prevent. But if we can't prevent them, then we're going to take the best care of them after it's already happened.
So then to go back to the beginning, preventing the risk factors, other than things you have really no control over, so back to the blood pressure, cholesterol, things that people can control if they choose to get up and exercise and control their blood pressure, take their medicine when they're supposed to. Anything else you want to add about stroke?
The acronym that Marion and Linda referred to from the American Heart, which is FAST, F-A-S-T. I love the T, and I cannot emphasize the T enough, because the time. If you're suspicious of anything, whether you're the patient or a caregiver, please call 911. Let the professional come. Don't take a chance. Don't go to sleep and say in the morning it will get better. St. John's, as you know, I belong to St. John's. St. John's is and I'm not promoting St. John's, but St. John's is the first hospital in Westchester. We were the first hospital to get the designation as a designated stroke center back in 2009. But wherever you are, you could be in Queens, don't say, no, I'm going to cross the bridge and come to my hospital, my St. John's. We prefer you to come to us, but time is very important. Go to the nearest emergency room if you can. Call 911 from wherever you are. The sooner, the better.
Thank you, Doctor. Any other questions? No? We're all good? Anything else you'd like to add? I think we covered it. So I'm going to thank everyone for joining us tonight, and thank you to our speakers. Really appreciate it, and good night.